So right now, it's a great pleasure for me to introduce our first speaker to you. He's a skilled Harvard-educated surgeon whose major focus is neuroendocrine tumors. He actively engages in research, developing new biomarkers, imaging techniques for better diagnosis of NETs. So please give a warm welcome for Dr. Eric Liu.
So, I'm not underdressed. Marianne brought me to Orlando, the least I can do is wear a short sleeve shirt, right? Right? And look, I'm a walking advertisement for the meeting. So, if I'm going to work on a Saturday, I can wear a t-shirt with a cute zebra on it, right? Anyway, cute zebra on it. All right, so let me, before I start, I just want to show my gratitude and kind of dedication, not only to you guys, but really to the Wayman family. The things they've done are really, really extraordinary. She's been very well cared for by great doctors, and it's clearly a gift from heaven, because since she's been so well cared for, she's been able to kind of reach out and do these things for you guys, and to support us, and to support Gene, and to support Phil, and to support Tom, and everyone else. So I just want you to know that this is an extraordinary family. And the way it works right now is basically Marion gets on the phone, calls me, and tells me what to do, and I just do what she tells me to do. Sometimes she'll text me if I'm a little bit busy. So it's my job, I think we're kind of assuming that you guys are really quite well versed already in things that are the basics of neuroendocrine and carcinoid. And if you're not, you'll pick stuff up. And if you don't understand something or something's been going on, there are a lot of doctors here who have a lot of experience who can help you. Most of it bottled up in gene altering. So don't hesitate to ask questions. Everyone here is super, super nice, really super nice. And just grab one of us in between and ask us something, and we'd be happy to help you as best we can. But my job, at least the job I was told to do, was to tell you about this gallium-68 scan and how it relates to PRRT. And I didn't realize actually initially that I was going to be the very first one. So if this is not clear to you, just feel free to raise your hand, and I'll kind of answer it, because I didn't kind of make it as a generic kind of thing, but it's kind of generic. So just ask, and I'm happy to stop. And we have, I think, 45 minutes, so it's plenty of time. So we'll talk about gallium-68 scans and their relationship to PRRT and the efficacy of PRRT. So let me just kind of give you a little bit of a background. So I'm a surgeon by training, and so we go and we cut these things out. And what I have come to realize is that each person who walks through that OR, or each person who walks through that clinic, is just a little bit different from the last patient that walked out. So here's one. This is a very kind of classic tumor in the small intestine. Here it is right there. Nothing fancy, nothing big, but that's a tumor that's probably been there for 10, 15 years, and it's caused a bunch of metastases. Here's one that comes out of the pancreas. I cut this out of a lady who was completely asymptomatic and gone to the emergency room because she had, a little bit of flank pain. Here's another one from the pancreas. You can see it's just this little waxy colored tumor. Here's another one from a lung we took out from a lady who came to visit us from Utah. And you can see that big ball where that stitch is. So these are from the lung. So they're all different, And kind of what I've learned over the couple of years that I've been doing this is that they're all different. They're all different. So I kind of liken it to, Baskin-Robbins. 31 flavors, and clearly Baskin-Robbins expanded now because diversity is the key to your good portfolio. But that's kind of how neuroendocrine tumors are. If you said carcinoid, I'd have to say, well, what kind of carcinoid, right? And then you tell me what kind of carcinoid, and I say, well, how does it behave? And there's so many of these little different things that just imagine if you're going to an oncologist who had maybe seen one or two carcinoids in their years of practice, and they had never really seen this disease, and all they could read was literally maybe like a page of it from their oncology textbook. How well do you think they could possibly take care of you? Right, probably not so well. And it's not that they don't mean well, or they're not super smart, or they're not well trained. It's just that it just takes experience. It just takes experience, because you have to see all of these different flavors in order to kind of understand what's going on. So now the question which I would pose to you with this picture in front of you is, what is common between all of these ice creams? Come on, makes you fat. Makes you fat. What else? What else? What's? They're all cold. Oh, that's good. Okay, they're all cold. I didn't think about that. Although I have had ice cream melt. I used to live in New York City, and it was really hot. We walked by the Haagen-Dazs, like, oh, it's the most delicious thing ever. And then you walk in, it starts to melt the moment you walk out the door. So, okay, so yes, they're cold. What else do they have?
They all have the same foundation.
What's that?
They all have the same foundation, the basic makeup.
Okay, so they're all kind of made out of milky kind of things. That's pretty good. That's pretty good. I didn't think about that. I thought someone was going to say they all had sugar. But they don't all have sugar, apparently. Yeah, some of them are sugar-free things. Oh, that's pretty good. All right. So, well, I was going to say, the one thing that these all have in common, they'll have cones. I thought that was pretty good. Oh, cones. And that is kind of like our neuroendocrine tumors. So here is a cell membrane, okay? And those little colored things are what we call somatostatin receptors, okay? So somatostatin is a hormone that your body naturally produces, and its basic function is to shut down your kind of endocrine system, okay? It's a global brake, think of it that way. And so what happens is, you can see the little somatostatin, the little somatostatin molecules, which are green there, bind to the receptors on the cell surface, and they instruct the cell to be quiet. Okay, you can see those geysers going off in the background. That's all hormone that's coming out. But once the receptors are activated, all that stuff starts to shut down. So what is somatostatin? Well, guess what? It's octreotide. It's sandostatin, okay? So here is another little still graphic where you can see the octreotide binds to these different kinds of somatostatin receptor, and they basically tell the cell to be quiet or to not grow or to do things like that. And so we use it kind of as a pharmaceutical agent, okay? But you can actually do fancier things with it. And Covidian, which is here, Mallinckrodt, which is here, they've actually put a light bulb behind it. So now they can actually take pictures, right? And all of you have heard of this. It's called an octrea scan, okay? Very clever, oct for 8. So octrea scan is very, very good. So we call that somatostatin receptor scintigraphy, so taking pictures, okay? This is not rocket science. You'll follow along as you go along. Now, the thing that the Europeans have done, which is really novel and interesting, is they put a bomb behind it, right? So we always struggle because, we don't have good kind of chemotherapeutic agents. I mean, they're developing, but not great chemotherapeutic agents for neuroendocrine tumors or carcinoids. So what they said is, well, look, we already have this biology, we take pictures with it, well, maybe we can make it into a therapeutic. And don't get me wrong, I think almost every oncologist in every field, in every different type of organ system would kill to have such a beautiful target as we do, okay? And so we've exploited this not only for our diagnostics and imaging, but also for our therapeutics. So we call this peptide receptor radionuclide therapy, so PRRT. You may have heard about it. It's relatively widely available in Europe, in some other places in the world. We have some Australian friends who do it. There's a new trial that's just kind of up and running. It's not quite there yet, but it's something that's exciting. At least we're having some of it. And so that's kind of what it is. That makes sense, right? So let me tell you a little bit about it. So here's the alphabet soup. So something called SRS, so somatostatin receptor scintigraphy, that's octrea scan. So those are pictures of your somatostatin receptors. What it does is it's based on something called SPECT, which is called single photon emission computed tomography. And that's kind of an older technology used for taking pictures of the body, okay? The newer technology is something that's called PET, so positron emission tomography. And so I kind of liken it to looking at a flashlight versus looking at a laser beam, okay? So if you are, flying over Orlando, right, and you see all these lights from the streets and things like that, it's just kind of a generic kind of light that kind of shows up, right? But if you took a laser pointer, right, and you pointed it at you in the airplane, you would see a very, very focused beam that comes out, right? And that's kind of the difference between SPECT and PET. And I'll show you some pictures on why I think it's makes such a big difference. And then here's PRRT. And if you go to Germany, they call it PRRNT. Same thing. But the neat thing about it is it's kind of this principle of theranostics, where basically you have a therapy that's linked to a diagnostic. Okay, so you may hear these words as you kind of go through your journey. Okay, so here's an example of some imaging. Okay, and I'm sorry I didn't put more introductory slides in here, but if you want, I can show it to you later. So this is there's a friend of mine. His name is Dr. Pommier, Rodney Pommier. He's a very, very, very fine surgeon at the University of Oregon. And he said, Eric, I've got this guy, I've explored him like 3 times. His gastrons keep going up. I can't figure out what's going on. I can't find it. I said, okay. So he has a surgery. And if still his gastrons are elevated. And he says, I can't find it. So I said, fine. He comes over to Vanderbilt and he gets his gallium scan. And you can see it. I'm sorry, I can't point it to you, but you can see it there. You see a little black hard dot in the middle, right? So that was his tumor. And then he texts me back. He says, hey, Eric, just went after occult gastronoma. It was right where the gallium scan showed it to be. Score 1 true positive for you. So I write back to him. I said, oh, sweet, you're my hero. And he writes back to me, hey, here's a picture of the sun with Venus going across it. I'm just like, that's a great picture, but, he's really big in astronomy. He really likes that. But, so it just goes to show you, it's a very useful tool. So here's another picture of a fellow who actually I was going to operate on. And he came down with an octrea scan, just like you see here. These are literally images that came on his disc. And you can kind of get a feeling for it. It's kind of a little bit of a fuzzy image, but it's not bad. I mean, it's really pretty good compared to what we used to have. And what you can see is he doesn't seem to have a whole lot of burden of disease, right? And so he has a carcinoid, and I saw it on his scan. I said, okay, well, we'll take out your primary, and we'll debulk you. That's kind of the thing that we do. But he had a couple of other unusual findings, right? And so I said, well, why don't we go ahead and get a gallium scan of you too? So we get a gallium scan on him on Friday, and his operation is scheduled for Monday. And I said, well, gallium scanner was empty. I said, well, let's do this gallium scan. And he turned out to have this. Right. So this was a real problem. So obviously I canceled his operation on Monday. And I said, we have to regroup and think about this. And it made a lot of sense because he was having problems with his bone marrow. Right. It was very, very subtle, but it just didn't feel right to me. It didn't smell right. So we got the scan, and it actually turned out to completely change his course of treatment. Right. So it was a very important piece of information. And certainly I would not have routinely gotten it in him because I can't routinely get a gallium scan. But it kind of makes me think maybe we should routinely get gallium scans because you do get a lot of information out of it. So now I say, okay, well now I've shown you a lot of pictures, right? And the pictures are great, and they do affect your kind of knowledge. But now what do I do with that, right? What do I do with this young man who has all this stuff, right? So I said, well, I think that what we should do is we should go ahead and send you for PRRT, right? Because he has a carcinoid, so we don't have a real good kind of chemotherapeutic systemic therapy for carcinoid. So let me just show you a little bit about what this PRRT is. So remember I told you that they're the receptors that are kind of floating on your cells, okay, the surface of your cells. And then what you can do is you can take your octreotide molecule, and a lot of you guys in this room I know take octreotide. It's about as close to a miracle drug as you can get, right? I mean, it fixes a lot of symptoms, makes people feel really much better. I mean, in some formulations you can take it once a month, So here's the little octreotide molecule, and what they do is they put a little bomb behind it. And that little bomb is something called lutetium-177. It's a radioactive isotope. It binds to the receptors and then goes into the cell and then continually irradiates those tumors for weeks. Okay, and that's really the beauty of it. So you get this infusion, and it just goes in there and it treats it. And that's what it does. You get these little these little isotopes of radiation going inside it, and it just continually fires off a little bit of radioactivity. And that's kind of the only way you can treat these things really very effectively when you have a larger kind of burden of disease that's not just localized in one place. Right? If it was just in your liver, Okay? I mean, I or Dr. Boudreau, we could go and cut those things out. If it was just in your bowel, we could cut it out. If it was just in your pancreas, we can cut it out. Heck, if it was just in your neck, we could just cut it out. But when it's in your bones and it's kind of spread all over, we can't do that effect. Really, what we can't do is we can't do any benefit for you, right? So the reason you come to see someone who specializes is because we can make very careful judgments about you. So what is the risk and benefit ratio of having half of your liver whacked out? Right? That is no easy feat for you to go through, right? And, if you're young and you're strong, sure, yeah, maybe you can get through it. But, maybe if you have some comorbidities, maybe that's not so easy, right? Or maybe you're young and strong and you have a complication from the operation, right? And then, then the question is, what kind of benefit have you had? So we think very hard about these things in order to make sure that you guys receive the great maximum benefit from any risk that you guys assume, right? So this is one such case. So let me just show you. I like to show this because it makes me feel smarter. I have this periodic table taped to the wall of my office, so that when people walk in, they look at it and think, oh boy, he actually maybe does know what he's talking about. So there are two isotopes that are given. Okay, so you may have heard of these two before. One is called yttrium, okay, which is that Y right there, okay, and one is called lutetium. And the yttrium is you can kind of think of it as a first-generation isotope. And the lutetium you can kind of think of as a second-generation isotope. They have slightly different properties, and I'll show you the differences, and you can kind of get a feel for it. But that's kind of what it is. But I always say, well, the lutetium, maybe someday we'll spell it correctly, and it'll be spelled that way. Thanks for laughing. I really appreciate that. It's early in the morning. Gotta get you going. So here are the two isotopes. They are rocks. That's what they are. They're heavy metals. Okay. So the yttrium, which is the kind of first generation medication, has a half-life you can see there of 64 hours. So it lingers in your body for a long time, and it's something that's called a beta emitter. And a beta emitter gives off a certain kind of radiation which can actually damage and kill those cancer cells. Okay. Its path length, in other words, the amount of effect that it has, is a slightly longer path length. It's about 2.7 millimeters. But you can just imagine if it's circulating your body and it's taken up by all your different cells, you can get really quite a nice crossfire kind of killing of the tumor. Right? It is not perfect by any means. Anything that has effect is going to have some kind of toxicity probably. And so the problem is you get some poisoning to your kidneys and you get some poisoning to your bone marrow. Right? And that's the same pretty much for all of radiation therapy essentially. So the second generation is something called lutetium. Lutetium is a little bit more advanced because it's not only a beta emitter that can kill, but it's also a gamma emitter, which means you can take pictures of it. So it's kind of like gives off the same type of picture type of radiation that you see on your Octria scan. So there are some people who are kind of playing with it as both an imaging agent and a therapeutic agent, and that's really, really quite exciting. Now look at its half-life. The half-life of lutetium is actually almost a week. All right. So that means that once it's taken up into your body, once it's taken up by your cells, your tumor cells, it sits there and percolates for days and days and weeks really. And so the way that it's given in Europe basically is you go for your therapy, you make sure it's safe and you can tolerate it and you're a good candidate. They make sure your Octria scan is strong or your gallium scan is strong, as I showed you. And then you're seen, and then this is not sexy, all right? As like fancy as it sounds, it is not. They put an IV into you, they hang a bang there, they stand behind a lead shield, and they turn this thing on and it just drips into you. And you just kind of sit there and you let it drip into you. And that's pretty much it. That's it, right? I mean, they give you some more medication to kind of protect your kidneys and to help you from, be feeling nauseous and things like that. So there's some prep to it. But that's it. They take the IV out, you go about your business, you're kind of glowing radioactive, for a couple of days, and then you go home. And then you go back about 8 weeks later, and you repeat the thing over again. And then you do it again another 8 weeks later, and you do it again another 8 weeks later. And so the standard protocol, which was actually really championed by a brilliant man named Eric Krenning in the Netherlands, that's the Dutch protocol, the Rotterdam protocol. So they do it 4 times, and they space it out by about 2 months. It's not perfect, that's a showed lutetium. You can see here the path length's a little bit shorter, so some people think maybe for bigger tumors yttrium is better, maybe for smaller tumors lutetium is better. I don't think that's really been totally worked out. But there is real toxicity to it, right? So if you walk in the door and you have problems with your kidney or your bone marrow or your liver, you may not be a strong candidate for it. But most of the time, people actually tolerate it pretty well. And so you can get a little bit of kidney toxicity, and that tends to be cumulative over the years. And in fact, it is the kidney that limits the amount of radiation you can receive. Everyone always gets a little ding in their bone marrow, okay? So that means that your white blood cell count may drop a little bit, your platelet cell count may drop a little bit, you may become anemic, but it's very similar to the the chemotherapeutic agents we give now for all different kinds of cancers, right? And very frequently, all those counts come back. And then when they come back, it's time for your next one, and then your next one, and your next one. So that's kind of how the therapy works. Does that make sense? And really the goal is to kind of keep your disease minimally stabilized. So here's an example. Now this is a very extreme example, but that's my job to show you the really extreme ones, right? So here's my friend from Sweden. Ulrika has been treating hundreds and hundreds of patients with this lutetium therapy. And when she first got started, she had this really tough case. He was a 47-year-old gentleman who had a metastatic insulinoma, right? So an insulinoma is the one that makes insulin, and it makes your blood sugars drop constantly. And most of the time, thankfully, we can actually cut those things down. A lot of people are very much cured at it. But this particular gentleman had it all over his body. So he was actually in hospice, dying, right, in his 40s. And they said, what can you do for this guy? And they said, well, we have this new therapy, and we'll give it a shot. And so they gave it a shot, and in fact, it worked really, really, really well, right? So it cleared up all his tumors, and he was able to get off hospice, and his quality of life, completely reversed, right? And so, anyone who's come to see me, I give the same spiel every time, which I discovered is not that different from Dr. Woltern's spiel, is basically, I try very hard to focus on your quality of life, right? Because most of the time, I can actually fix a lot of your quality of life. The quantity of life is, we try our very, very best, but sometimes we can't do anything about that. So quality of life is still very important. So this man, all of a sudden, his quality of life was completely reversed, right? Now, they didn't have experience with it. They didn't know how much to give. They were just kind of still working with it. So he did recur eventually, because they only gave a couple of therapies. But you can see there is something to it. There's something to it. So here are the people that give lutetium in PRRT around the world. We have a nuclear medicine physician in Houston who gives it, Dr. Delpasan. And we'll soon have 14 centers all around the country. The United States giving it for midgut carcinoid in this NETTER-1 trial. But it's pretty much a European thing, right? So a lot of the European centers have it. There's a center in India that gives it. The Australians give it. There's a fellow in Israel that gives it. So it's available. But if you look in Europe, that's really where it's dominated, right? So here it is in Rotterdam in the Netherlands where it first started. And here are all the other centers around Europe. And I think this is actually a little bit out of date because I think there are more centers now, even in Great Britain, that give it. So, and I'm trained in Sweden, so that's where it is in Uppsala. So here's kind of what the data shows. And so the data show, and you can, kind of take it for what it is. This is a trial from it's a retrospective trial from the Dutch, and they published it in 2009, so even these data are a little bit on the old side. But basically what they found is either it worked or it didn't, okay? And for the patients who had stable disease or even some kind of response, they were able to get really nice cumulative survivals. You can see they're over 80% at 3-4 years, right? So those are months. It's quite a long time. And for the people who didn't work, it just didn't work. They progressed, okay? And there were some predictors, which I don't think are perfect and are being kind of teased out as we go along. But basically they said the better and stronger you were and the less disease you had, the better you did, right? So it's not really rocket science in itself. But you can see there that they were starting to kind of tease these things out. So they looked at 504 patients, right? And what they found is their progression-free survival was actually 40 months, okay? So what does that mean? Progression-free survival means your disease is stabilized, right? And then it doesn't grow. And so that was the great thing. Their median overall survival from the time of treatment was 4 years. and the overall survival from the time of diagnosis was 10 years, okay? Now, these data are a little bit deceptive, okay, because a lot of the patients, and it's hard to know exactly who they treated and what their situations were. But remember, in people who have carcinoma neuroendocrine tumor, it's very, very important to just get disease stabilization. It's a little bit different from, say, like a liver cancer or a pancreatic adenocarcinoma, where they're very kind of consumptive cancers. So you get it, you lose weight, you really start to, you have difficulty eating and those kinds of things. Many patients can do really quite well with their carcinoid and live very well for many, many years until the very end when their intestines start to run out, their liver starts to run out, they have uncontrollable hormones. So even that disease stabilization is very important. And so you can see here in the various kind of tumors inside there that a lot of the patients have the disease stabilization, and that is really considered very much a success. But at the same time, if you can kind of take care of these patients very well, you can still get very, very good survivals as well. So this is just one tool. It's not a miracle. It is not everyone should run out and get it, but it is one tool in the toolbox for treating neuroendocrine tumors. Okay. So the question was, how does the gallium kind of, associate with this? And so I told you the gallium is a nice imaging test, right? The reason it's particularly good is because it's the exact same octreotide molecule with just a light bulb behind instead of the bomb. So they go to the same place, they bind to the same tumors, they do all those kinds of things. So the Germans did a study, and they said, well, what if we take our gallium dotatate, and some of you have had this scan, and this is the molecule that we use, and they want to know, well, if you have a good response to your, based on gallium, will that predict if you have a good response to your lutetium? So basically, you get someone, you consider them candidates for lutetium, you give them a dose of lutetium, and you find out what happens. And what they found is that if the tumors responded to even the first dose of lutetium by driving down the signal of the gallium, that you were going to have a good response. Okay, and you can see here they divided up into a couple of different groups here. But if you look, you can see it says progression-free survival in that left curve there. You can see how wide they've split. So the ones who had a good response, a decrease in their intensity of their gallium, they had a higher kind of survival. Whereas if they had a poor response, they were going to progress more quickly. And they looked at certain parameters and things like that, and so which is really important for us, because as we gain more experience in the United States, these are information we're going to need to know and studies we're going to be able to do. But it seems to have a correlation, okay? And it's not, it kind of all makes sense. Here's another study that came out, and they said, well, how about if we look at the PET scan in a different type of tumor, something called a meningioma? So it's a tumor that actually is in your brain. And what they found is that if the PET uptake, so basically the signal that came from your PET scan was very good, in fact, the uptake of the therapeutic was very good as well, too. So there's a good correlation between the two. And you can see here in the graph below, you can see the uptake was very high when there was good uptake inside the imaging agent, whereas there was poor uptake if there was poor uptake in the imaging. So they all kind of go along. And then finally, and here's another graph, and you can see here basically they correlate very well. See how the slope goes up? So it's almost like a one-to-one correlation. And then finally, this paper just came out this week, actually, so I just kind of stuck it in last night. So they said, another German group, they said, well, really, can I use my imaging agent to predict the response to the PRRT? And this group uses yttrium-90, so you can see the yttrium-90, the Y90 DOTA tox, so it's a slightly different molecule. And how does that relate to the imaging that was done before? And they said, well, basically, if someone had a strong image, so what we call an SUV max, you can see all the way on the far left side of the slide there, if they had a signal that was greater than 20, okay, and we can go there, we can circle it, and the computer can tell me exactly how much signal is coming out of it. If it's very high, did they do well? And you can see here that people who had a very good response in the green did very, very well, okay? The kinds who were in the middle didn't do so great, and the ones who didn't have strong signal didn't do so great. So this is all kind of confirming the fact that there is this marriage between the diagnostic tool and the therapeutic tool. And it is as you would expect, right? But it has to be tested, because just because you think something's going to work doesn't magically mean it's going to work, okay? And so, but with this information, and these are very good scientists and doctors, with this information, it gives us more and more strength and supports what we've always thought, that in fact the imaging and the therapeutics go very well together. On the curve on the side, on the right side, you can see that's something called a receiver-operator curve. And basically, if you have the gray line in the middle, it's diagonal. If it follows that line, there's no correlation at all. Okay, it's just totally random. But the more curved it is towards that upper left-hand corner, the better predictor it is. And you can see there, this thing's almost just like a curve right up to the upper left-hand corner. So it's very, very encouraging. So this is really why we've been using this gallium and why it's changed the course of therapy. And it gives me a lot of kind of confidence and strength that what we're doing is we're kind of on the right track. So here it is. That's what lutetium looks like, okay? I bought some. It wasn't, it's kind of like when you get baptized and you kind of expect like electricity to come out when they pour water on your head, and then they just pour water on your head and you just feel wet. That's what it was kind of like. It's like, this is it? This is what all the hoopla is about? And that's it. That's what it is. And so I'm very excited because as the trial is now opening up, and we just opened ours this week, and the other centers around the country get it. Hopefully we'll be able to test this therapy and someday really be able to provide it, because I think there is something to it. You have to select it for the right patient. You have to remember it's one tool in the toolbox. We'll have to figure out when to use it. Maybe it should be used before we do your surgery. Maybe we should use it earlier instead of chemotherapy. A lot of these questions, maybe we should use it with chemotherapy. So there are a lot of these questions that are unresolved, and hopefully we can kind of tease them out. And as long as we kind of practice good science and good clinical trials and really kind of protect you, and while at the same time, developing a lot of knowledge, it's the only way we'll be able to really provide you with the very, very best care. And so it's just going to be a great tool. So I'm very excited by it. And remember, this is always what it is. It's always about you, right? It's always about you. I had dinner with the ladies last night, and they said, why do you do what you do? And I said, well, sometimes you just have to think there's a greater force that kind of just brings you here. But then the thing I said is, it's not about me, right? I mean, I could go get my wife always says, well, why didn't you get a job on Wall Street, then you wouldn't be in so much debt. I said, well, it's probably true. I said, but it's not about me. It's about you, right? And so all these things I do, and, all the things I try to learn about and study and things are really so I can improve my ability to care for you. Because I have young children, and I know all you want to do is you want to see your children grow up, you want to see them be healthy, you want to see your grandchildren grow, you want to live a good, healthy life. You don't want to be tied to the bathroom all the time, right? You don't want to keep thinking about these things all the time. And so that's, that is the most important thing to me, is that you do well. And so I've been very blessed, and we surround you with all these great, smart doctors, and we have these wonderful conferences so that you guys can really be well educated, so we can work together as a team. Because it's a team that we put around you, but you guys are very much part of the team. And this is my team. I'm very, very blessed to work with amazing people. I used to have a really great nurse practitioner, as Dr. Walterman will attest to, but she's now left me, unfortunately, so I'm very, very sad. And she would come back in a second. But, all of the healthcare system is really going through a very difficult time right now. And so, unfortunately, we were unable to retain her. But she is brilliant. And we have a website, so if anyone's interested, you're more than welcome to take a look. We've got some interesting things, just basic information. But we also have kind of the things that we do. And, I Facebook a lot, so you guys are more than welcome to friend me. Dr. Oberg is actually coming to visit us in Nashville on October 1st and 2nd. So that's very, very exciting. We're going to see patients and talk about cases and things like that. So it's very exciting and fun. And so that's what I have. This is Nashville. So anytime you want to come, all right. Nashville's a really cute town, right? Gail and Cap will attest to that. It's a really fun town. It's pretty easy to get to. The airport's really easy, and if you're lucky, maybe you'll see my neighbor Taylor Swift, or Garth's favorite restaurant is a pancake restaurant right down the street from Vanderbilt. Keith Urban, his kid goes to the same school my kid goes to. Nicole. And of course, Karen Underwood. She's so cute. Okay, that's it. That's all I have.